Usually when we think about building something complex, like a skyscraper, there's this expectation of precision, right?
Right. Very
You
precise.
follow the blueprint, you pour the foundation, you put up the steel beams, and if the beam is bent, the inspector just points at it and says, fix that before we move on.
Exactly. It's very visible and very linear.
Right. But a human child, they have to keep growing while the foundation is literally still settling. So welcome to the deep dive.
Glad to be here.
Today for you, the listener, we are looking at a stack of sources, specifically a really detailed clinical study guide on pediatric developmental disabilities.
It's a fantastic guide.
It really is. And our mission today is to decode the pathophysiology, the risk factors, and the vital nursing care strategies for 5 major pediatric conditions. Because it's not just about memorizing facts.
No, not at all.
It's about understanding the why behind the care so you can become a truly culturally competent caregiver. But before we get into the specific conditions, we need to set a baseline.
We do. And that distinction between the static blueprint and the ongoing construction, that's vital to everything we're talking about today.
Right.
In clinical terms, we separate growth from development.
Okay, break that down for us.
So growth is strictly physical. It's the expanding square footage of the house, to use your analogy.
So we're talking height, weight, that kind of thing.
Exactly. But development, that's the behavioral complexity. It's wiring the electricity, getting the plumbing to actually work together.
It's how the house functions.
Yes. Ultimately, it's the house's ability to withstand a storm. It is the capacity of a person to adapt to their environment.
Okay, let's unpack this. Because if development is about the capacity to adapt, what happens when a toxin hits the construction site before the foundation is even poured?
That's a great question.
I'm going to start at the very beginning, prenatal development, and look at fetal alcohol syndrome, or FAS.
Right.
We all know maternal alcohol consumption is the cause, but the mechanics of how it damages the fetus are, well, they're frankly fascinating.
It acts as a teratogen. See, the fetal liver isn't developed enough to process alcohol.
Oh, wow. So it
Yeah.
just sits there.
Yeah, it remains in the fetal bloodstream in incredibly high concentrations. And the alcohol fundamentally disrupts how embryonic cells multiply and migrate.
And that specifically affects the central nervous system, right?
Yes, profoundly.
Now, the clinical study guide points out very specific facial markers for FAS, like a smooth philtrum, which is that little groove above the lip, thin upper lip, and narrow eye openings.
Yes, the small palpebral fissures.
Right. But I guess I don't really understand the physiology here. Why does an alcohol toxin specifically target the lips and eyes? Like, what's the connection?
It comes down to a really specific group of embryonic structures called neural crest cells.
Neural crest cells, okay.
Early in gestation, these cells migrate. They literally travel to form both the facial structures and the central nervous system.
So they're linked.
Exactly. And the alcohol is highly toxic to these migrating cells. So when you see those specific facial abnormalities, you are actually looking at a visible external marker of a hidden neurological disruption.
That makes the head circumference measurement make so much more sense.
Right.
The guide mandates tracking weight, height, and head circumference at or below the 10th percentile for these infants.
Which is critical.
So the small head isn't just like a physical trait. It's a direct indicator that the brain itself was physically restricted from developing.
Which completely shifts the entire nursing process. I mean, you cannot cure missing brain cells.
No, you can't.
So the priority nursing diagnosis here often revolves around delayed growth and development or impaired verbal communication.
So what does the care plan actually look like then?
It hinges on aggressive early behavioral interventions. Nurses have to teach the family how to manage the child's poor memory, their communication deficits, maybe even motor problems or seizures.
You're essentially giving the child workarounds for that early neurological damage.
Exactly. You're teaching them how to adapt.
Okay, so we just looked at an environmental toxin, totally derailing the blueprint. But sometimes the blueprint itself just has a structural typo, right?
Right. Driven by genetics or maybe early nutritional deficits.
Like a maternal lack of folate.
Yes, folate deficiency is a major risk factor here.
Which brings us to cleft lip and cleft palate. About 1 in 700 babies are born with this.
Yeah. So during the first trimester, the structures of the face are supposed to meet in the middle and fuse together.
Like zipping up a jacket.
That's a good way to put it. And when they fail to fuse, you get a visible split. A cleft lip extends up toward the nose, and a cleft palate is an actual opening in the roof of the mouth.
Connecting directly to the nasal cavity.
Yes.
Now, looking at the surgical timeline for a cleft palate in the sources, I was genuinely confused.
How so?
Well, the lip is usually repaired between 3 to 6 months of age, but the palate repair waits until the child is between 6 and 24 months old.
That's standard, yes.
Why delay? I mean, if there's literally a hole in the roof of the mouth, why not fix it immediately so the baby can function normally?
It's a tricky balance. See, the human brain is desperate to communicate.
Okay.
If surgeons don't close that palate before the child begins attempting complex speech sounds, the child will actually invent entirely new, incorrect ways to use their throat muscles to make sounds.
Just to compensate for the hole.
Exactly. So we are racing against the brain's own adaptability to facilitate proper speech.
Well, then why not do it at like 2 months?
Because surgeons have to balance that against the physical growth of the jaw. Fixing the palate too early can permanently restrict mid-facial bone growth.
Oh, wow. So it could mess up their whole facial structure and tooth alignment later on.
Right. They also follow the surgical rule of 10 for the lip repair, which is interesting.
Oh, yeah, the sources mentioned that. Ensuring the infant weighs at least 10 pounds.
Has a hemoglobin of 10.
And is 10 weeks old.
Exactly. It basically proves they're robust enough to survive the anesthesia.
Wait, I'm stuck on the physics of this in the meantime. Before that palate surgery happens, how does the infant eat?
With difficulty.
Right. Because if the roof of the mouth is open to the nasal cavity, they can't create a vacuum. They can't suck milk out of a bottle without inhaling it straight into their lungs.
And that inability to create negative pressure makes the priority nursing diagnosis risk for aspiration and imbalanced nutrition.
That sounds terrifying for a parent.
It is. The primary evidence-based intervention involves modifying the actual mechanics of feeding.
Like using special bottles.
Yeah, nurses use special wide-based nipples or compressible bottles, and they train parents in a highly specific rhythm called the ESSR method.
Right, the ESSR method. Let's break that down. Enlarged nipple opening.
Stimulate the child to suck.
Swallow normally and rest.
Right. The caregiver is essentially manually pulsing the milk into the baby's mouth in time with their natural swallow and breathe rhythm.
That's so hands-on.
Huh.
And post-operatively, I imagine protecting that delicate repair is paramount.
Oh, absolutely. A fresh surgical site in a baby's mouth is incredibly vulnerable to tearing.
So what does the care plan mandate?
Absolutely no hard objects.
Why?
No pacifiers, no straws, no forks, no tongue depressors.
Nothing that could poke the roofs of the mouth.
Nothing. The infant even requires specialized elbow restraints.
Wait, really?
Yes. So they literally cannot bend their arms to put their own fingers in their mouth.
Wow, that's intense.
It is. And frequent burping is also essential because these infants swallow excessive amounts of air, which can cause really painful abdominal distension.
Okay, so far we've been talking about structural formations of the face and mouth. Let's look deeper into the internal wiring.
Let's do it.
What happens when the brain's motor centers are damaged, but the rest of the body is, perfectly formed?
You're referring to cerebral palsy, or
Yeah.
CP.
Yes.
The pathophysiology here is defined as a chronic injury to the motor centers of the brain.
And this causes those deep neuromuscular problems, right?
Yes, specifically spasticity, which is extreme muscle stiffness or dyskinesia.
Which is the involuntary, uncontrolled muscle movements.
Exactly.
Now, the term non-progressive threw me off initially when reading the sources
It trips up a lot of people.
because the motor impairment in cerebral palsy lasts a lifetime, so it feels progressive. But what that actually means is the original brain lesion doesn't spread.
Right. Whether it was caused by low birth weight, anoxia from a lack of oxygen, or a maternal infection like rubella or toxoplasmosis.
The neurological damage itself is a static event. It doesn't worsen over time.
The lesion is static, yes, but the child is continuously growing,
Right.
and that is where the clinical friction occurs. You have a growing skeletal system fighting against tight, spastic muscles that just aren't receiving the correct brain signals to relax.
So the bones are pulling against tight rubber bands.
That's a great analogy. That's why collaborative therapies often involve major orthopedic surgery.
Like the Achilles tendon lengthening mentioned in the text.
Yes, or they perform a rhizotomy.
What is that?
It's where surgeons actually sever the overactive nerve roots in the spinal cord to forcefully release that muscle tension.
Oh, wow. And pharmacologically, they're using muscle relaxants and anti-seizure medications to quiet that systemic noise.
Exactly.
Here's where it gets really interesting, though. The manifestations are very distinct. A child with CP might show a persistence of primitive reflexes,
Yes, reflexes that a baby should naturally outgrow.
like the Moro reflex or the startle reflex. They stick around far too long.
They also exhibit delayed gross motor development and abnormal muscle tone.
But there is a critical distinction the sources emphasize here, and I want to make sure we highlight it.
Please do.
A child with CP might have severe physical limitations, speech impediments, or visual comorbidities, but their intellect can be completely intact.
Yes. Assuming a motor deficit equals a cognitive deficit is one of the most dangerous errors a care provider can make.
It seems like a terrible failure of care.
It really is. They might be completely cognitively aware, just trapped in a body that won't cooperate.
So what's the priority nursing diagnosis then?
Impaired physical mobility. The overarching goal is maximizing functional ability.
Which means preserving skin integrity from braces or wheelchairs.
Right. Preventing joint contractures. And ensuring the child has the communication tools they need to prove their cognitive presence to a world that, quite frankly, often misjudges them based on their physical movements.
That disconnect between the brain's signals and the body's mechanics leads us to another wiring issue. But this one is located far away from the brain, down in the gut.
Hirschsprung disease.
Yes, Hirschsprung disease.
So this is a congenital condition defined by the absence of autonomic parasympathetic ganglion cells.
Say that 3 times fast.
Right. But specifically, they're missing in the distal portion of the colon and rectum.
I like to think of the intestines like a factory conveyor belt pushing waste out of the body.
Okay, yeah.
In Hirschsprung disease, the motor suddenly stops at the very end of the line because those specific nerve cells, the ones that tell the bowel to squeeze and relax, they're just missing.
Exactly. The medical term is poor or absent peristalsis.
So because the end of the pipe doesn't squeeze, everything just backs up.
Yes. Feces accumulate and the bowel above the blockage dilates enormously.
So what's the red flag for nurses?
In a newborn, the immediate red flag is a delayed meconium stool.
That's the very first poop, right?
Yes. If a baby doesn't pass that first dark, tarry stool within the first 24 to 48 hours of life, nurses immediately suspect a lower bowel obstruction.
But what if it's a milder case and gets diagnosed a bit later in infancy?
Then the symptoms change. The baby might have a swollen belly, vomiting, and these very specific pellet-like or ribbon-like foul-smelling stools.
Ribbon-like, because the waste is being forced through a narrow, unmoving section of the pipe.
Precisely.
How do they even confirm that?
The definitive diagnostic tool is a rectal suction biopsy. They have to clinically confirm those ganglion cells are actually missing.
And the treatment?
Entirely mechanical. Surgeons must physically remove the aganglionic portion of the intestine.
You just cut out the broken part of the conveyor belt.
Basically. And often, the bowel needs time to heal, requiring a temporary colostomy to divert the waste to a bag on the abdomen before they eventually reconnect the healthy bowel to the rectum.
Okay, so post-operatively, there's a glaring, bolded rule in the nursing care plan that I saw.
The temperature rule?
Yes, absolutely no rectal temperatures.
None.
Taking a rectal temperature seems like the most routine thing in pediatrics. Why is it banned here?
Because it is a critical safety hazard. You have a fresh, delicate surgical anastomosis, a reconnection of tissue right inside the rectum.
Oh, I see.
Inserting a rigid thermometer could perforate the healing bowel wall,
Which would spill intestinal contents into the abdominal cavity.
causing a massive, potentially fatal infection, yes.
Wow.
So nursing care relies entirely on keeping the child NPO nothing by mouth-managing 5E fluids and carefully assessing bowel zones for the return of normal mechanical function.
We've covered missing brain cells, missing nerve cells, and structural gaps. But what happens when the physical machinery is perfectly intact, but the fuel and the environment completely fail?
Right.
Does the body just stop building itself?
It does. This syndrome is known as failure to thrive, or FTT.
And how is that diagnosed?
It's diagnosed when a child's weight falls significantly below comparably aged children, specifically dropping below the 5th percentile on standard growth charts.
The etiology is divided into 2 clinical categories in the sources, organic and non-organic.
Correct.
Organic makes sense to me from a purely physiological standpoint. There's an underlying medical or chromosomal issue.
Like a congenital heart defect, for example.
Right, which might force a baby to burn so many calories just trying to oxygenate their blood that they don't have any energy left over to actually grow.
Exactly. But non-organic failure to thrive is where the nursing assessment becomes deeply investigative.
This is the environmental side.
Yes. This is growth failure driven by the psychosocial environment. Profound neglect, a lack of parenting knowledge, poor feeding practices, or a deeply dysfunctional parent-infant interaction.
The physical manifestations are severe. You see cachexia, which is intense muscle wasting, where the body essentially consumes its own tissue for fuel.
You see a swollen abdomen and hypotonia, low muscle tone.
But the behavioral symptoms, those are what truly stun me. A baby suffering from non-organic FTT might actively avoid eye contact or physical touch.
Yeah, it's heartbreaking. A severely neglected infant learns that signaling for their needs, like crying for food or comfort, doesn't yield a response.
So they just stop trying.
They literally stop trying. One of the most telling clinical signs is a lack of age-appropriate stranger anxiety.
What do you mean by that?
Well, a neurotypical baby normally develops a healthy fear of strangers around 6 to 8 months. It's a protective developmental milestone.
Right, they cling to mom or dad.
Exactly. But an infant with FTT might not show that protective response at all. They might go to anyone, or they might just withdraw completely.
So what does this all mean? How do you even formulate a care plan for a diagnosis that spans both physical starvation and emotional neglect?
It's complex.
The priority nursing diagnosis here isn't just about calories. The sources highlight dysfunctional family processes.
Because you have to treat the child and the environment simultaneously. Physiologically, nutritional therapy involves high-calorie feeds.
Like special formula.
Yeah, nurses might use formula mixed to 24 calories per ounce instead of the standard 20, alongside daily multivitamins, tracking their daily weight meticulously.
But handing a struggling parent a higher calorie formula doesn't fix the root cause if they don't know how to feed or safely interact with their baby in the first place.
Which is exactly why the care plan demands observing and modifying the parent-infant interaction.
The nurses have to step in.
Nurses role model healthy adult-child interactions. They educate the caregivers on feeding cues and connect them with intense community support.
And there's a legal aspect too, right?
Yes. As mandated reporters, nurses have a legal obligation to escalate concerns to protective services if they suspect deliberate abuse.
So the expected outcome isn't just about the scale.
No. Steady weight gain is crucial, yes. But equally important is seeing the child begin to hit developmental milestones and witnessing improved, safer caregiver interactions.
All of this requires an incredible balancing act from the care provider. I mean, we are talking about rigid, life-or-death clinical rules like the ESSR feeding method or absolute bans on rectal temps, but applying them to vastly diverse human families.
Absolutely. And the sources frame this overarching duty using the PPDD framework.
PPDD.
Yes. Instead of just treating the acute hospital problem, the nurse's job is expansive.
Okay, let's walk through it.
They provide the immediate physical care. They promote early identification of developmental delays. They direct the family to community resources. They teach the intricate home care. And they discuss the emotional toll and long-term options.
Culturally competent care seems critical here. If you are directing a family on how to manage a colostomy bag or how to mix a 24-calorie formula, you can't just hand them a clinical pamphlet and walk out of the room.
Not at all. Culturally competent care means assessing how the family's specific cultural background views a lifelong developmental disability.
Like, is there a stigma attached to a cleft lip in their community?
Exactly. Or who is the primary decision maker in the family unit? You have to tailor the education to their reality, ensuring they actually understand the rationale behind the care plan.
A big part of that discussion has to be adjusting expectations, I imagine. With cerebral palsy, cleft palate, failure to thrive, fetal alcohol syndrome, and Hirschsprung, the ultimate evaluation of care isn't always achieving a complete cure.
No, it's not. Maximizing functional ability is the true metric of success.
Function over perfection.
Right. It's about utilizing tools like individualized education plans or IEPs to protect the child's rights in the public school system.
Promoting their social competence.
Yes, and ensuring the family feels confident managing the condition long term.
Well, we've covered a massive amount of ground today. We started with prenatal toxins altering neural crest cells in fetal alcohol syndrome.
And the structural race against the brain's adaptability in cleft lip and palate.
Right. We mapped the internal wiring disconnects, the static brain lesions of cerebral palsy, and the missing gut nerves in Hirschsprung disease.
And finally, we looked at how profound environmental neglect literally stalls physical growth and failure to thrive.
So you, the listener, now have the blueprint for the pathophysiology, the risk factors, and the deep evidence-based nursing interventions required for these conditions.
And as we wrap up, I just want to leave you with a thought that synthesizes everything we've discussed today.
Go for it.
We spend so much clinical time charting physical percentiles, obsessing over weights below the 5th percentile and heads below the 10th. But earlier, we defined development as the behavioral capacity to adapt to the environment. So consider this. Many of these children face profound physical or neurological barriers, yet they learn to communicate, to adapt, to navigate a world built for neurotypical and physically typical bodies.
That's true resilience.
It is. How might the unique psychosocial resilience of these children, their sheer capacity to adapt against the odds, force us as a society to completely redefine what it actually means to thrive?
When the original blueprint gets smudged, it doesn't mean the building can't stand.
Exactly.
It just means the architecture becomes something uniquely its own, requiring a completely different kind of structural support from all of us. Thanks for joining us on this deep dive.